Hello everyone, this is Dr. Saeed Al Nasser. This lecture is about a very common condition in the pediatric population, developmental dysplasia of the hip. This is the outline of the lecture that we will go through today. As you know, the hip joint is a ball and socket joint. To have a normal hip, the ball needs to be inside the socket, and the socket needs to be fully formed, and there should be full coverage of the femoral head by the acetabulum. So to define DDH, it is a disorder of abnormal development of the hip joint, particularly of the acetabulum, leading to a spectrum of problems that can occur afterwards. So DDH generally starts during pregnancy, particularly in the third trimester of pregnancy. DDH is a spectrum of disease, so every single case is not similar to another case. And this spectrum can start from a stable hip but with a shallow acetabulum, or what we call dysplasia of the acetabulum, or it can cause subluxation, which is a partial migration of the femoral head outside the acetabulum, or the hip can be fully dislocated. This generally is a very common condition. It is one of the most common and the most important conditions in pediatric orthopedics. The incidence generally is between 1 and 2%, but most of DDH cases are pure dysplasia without instability. The incidence of full dislocation of the hip joint is 1 to 2 in 1,000. It is a female disease. The female to male ratio is 7 to 1, and we will talk about that slightly later. Okay. The left hip is more commonly affected than the right, and 20% of cases are bilateral. Talking about etiology, there is not a single obvious cause for DDH, so it is multifactorial. The most important cause seems to be the intrauterine position of the baby and the tightness of the uterine space in relation to the size of the baby. But there are other causes like genetic factors like ligament hyperlaxity and shallow acetabulum, which can run in families. There are also some hormonal factors like the relaxin hormone, which is secreted in the latter stages of pregnancy by the mother, and this hormone crosses the placenta to the baby, but it only has receptors in the female baby, so it affects females more than males, causing relaxation of the tissues in general, and this laxity caused by the relaxin hormone can lead to instability of the hip joint. As we said, the intrauterine position is very important, particularly the breech presentation. And there are some postnatal factors, most importantly the swaddling. The picture on the left is the wrong way of swaddling the baby, and the right way is the picture on the right. So the legs should be always comfortable, and we should avoid the position in the left-hand picture, which is the extension and adduction of the hip joint. These are the most common risk factors for DDH. The first three are the most important. The firstborn child is always at higher risk because of the small size of the uterus, the genetic factors, as we said, malpresentation, particularly breech presentation, and also transverse lies can lead to DDH. There are other risk factors as described below. Please note the packaging disorders which we will speak about later. This slide shows the packaging disorders which can be associated with DDH. So what we mean by packaging disorders is the way of packaging the baby inside the uterus. If there is a mismatch in the size of the baby in relation to the size of the uterus, then these conditions can happen. For example, if the uterus is small in relation to the size of the baby, as is the case in the first pregnancy, these conditions can happen. On the other hand, if the baby is large, for example, children of diabetic mothers or large babies, more than 4 kilos, etc. This can also lead to a mismatch between the sizes of the baby and the uterus, leading to these conditions. And these conditions include, at the top of the list is DDH, and then we have metatarsus adductus, which is the top left picture, which is a medial deviation of the midfoot due to the intrauterine position of the baby. Also, the picture at the bottom is for torticollis, which is tightness of the sternocleidomastoid muscle, leading to an abnormal posture of the head with the tilting of the neck. This is also caused by the intrauterine position. And the picture on the right shows what we call a calcaneovalgus foot, which is again one of the packaging disorders caused by the position of the baby. Most importantly, all of these conditions in this slide, these three conditions, they are very obvious at birth, and they can be detected easily by the pediatricians or even by the parents. All of these conditions are usually self-limiting, so they do not need any particular treatment after birth, but they should warn us about the possibility of DDH. Therefore, these children will need to be screened for DDH. Now we'll speak about physical examination. These are two of the important tests when we examine a baby for DDH. The one on the left is the Barlow test, which is basically trying to check the stability of the hip joint and trying to get the ball to dislocate out of the socket. In a normal baby, the hip should be stable and should not sublux or dislocate. But in a baby with DDH, the ball can easily be pushed out of the socket. And to do that, you can look at the picture and maybe watch a video on YouTube. There are many videos that can explain the test. But basically, in this position, the hip is flexed and adducted, and a gentle axial load is applied from anterior to posterior. And if the hip is unstable, the examiner will feel a clunk around the hip joint, indicating that the hip is going out. The picture on the right shows the Ortolani test, which is exactly the opposite, trying to relocate a dislocated hip by abducting the hip and applying a gentle pressure on the greater trochanter to push the femoral head back into the socket. And again, you can feel and sometimes hear a clunk if the test is positive. This is another test for DDH. Please note that if the child has a dislocated hip, the affected limb will be shorter than the other side, and this will cause a leg length discrepancy. And this first test, the Galeazzi test, is designed to check for leg length discrepancy. The way to do it is to ask or to put the hip in 45 degrees of flexion and the knees in about 90 degrees of flexion, and then you check the height of the patellae on both sides, and then the height of the tibial tuberosities on both sides from the side. The picture on the top right shows that the right patella is higher than the left, indicating a leg length discrepancy. This leg length discrepancy is caused by shortening of the left tibia in this case. However, in DDH, the shortening should be on the femoral side. So when you look from the side, you will see that the on the affected side, the tibial tuberosity is shorter on the affected side, indicating that the femur is shorter. So this tells us that the femur is shorter on this side, which can be caused by DDH or by any other cause of leg length discrepancy. To understand this further, I advise you to again watch a video, and there are many videos describing and showing this test. The most important part is to know how to know whether this leg length discrepancy is coming from the femur or from the tibia or from both. In the bottom picture, you can see that this patient has asymmetrical thigh or gluteal skin creases or skin folds, which may be a sign of leg length discrepancy or DDH, but this is not a very sensitive sign. Before we carry on with the physical examination signs, I would like to draw your attention that the most important and sensitive clinical sign for DDH is asymmetrical abduction of the hip joint in the case of unilateral DDH. So if you notice that the abduction is less on one side, that is a very important sign of DDH. To carry on, there are many other physical examination signs for DDH. For late presenters or the ones that present after walking age, which should not happen, you can get problems with gait. The most common gait is the Trendelenburg gait. If the patient has a unilateral DDH, if the patient has bilateral DDH, then he or she will have a bilateral Trendelenburg gait, or what we call the waddling gait. Also, because of the shortening that can happen with the DDH, there can be different gait patterns, like toe walking on the affected side or bending the knee on the normal side. Here you can see this sign, the decrease in abduction, which is a very important clinical sign for DDH at all ages. With the chronicity of the problem, i.e. if the DDH becomes chronic without treatment, you can get a fixed flexion deformity of the hip joint or a flexion contracture, which can lead to increased lumbar lordosis as well. Now this picture here is a very important picture. It shows the X-ray of the baby soon after birth. You can see the bony parts and the cartilaginous parts. This tells me that the hip joint cannot be fully visualized on the X-ray in very young babies. Therefore, the standard for diagnosis is the ultrasound scan, which allows me to see the cartilage as well as the bone. And ultrasound scan is the gold standard for DDH diagnosis in the first 6 months of age. And X-rays, in fact, should not be used in this age group. There is no need for you to know the details of the ultrasound scan, but you need to know that it is the investigation of choice in young babies up to 6 months of age. But when you look at an X-ray of a young child to check for DDH, first of all, the X-ray should be taken in the standard position, AP position. It should be symmetrical. The iliac wings should be of the same size, which are in green color here. Also, the obturator foramen or foramina should be symmetrical. And then you need to draw some lines. The yellow line is the Hilgenreiner line, which is a line combining what we call the triradiate cartilage on each hip. And the second line is the red line, which is the Perkins line, which is a perpendicular line to the Hilgenreiner line, starting from the lateral edge of the acetabulum. So these two lines form a 90-degree angle and form 4 quadrants, and the femoral head most of the femoral head should be in the inferior medial quadrant in a normal hip. If it is located lateral or superior, then that can indicate DDH. The Shenton line in blue is an imaginary line that starts from the femoral neck and continues to the inferior part of the superior pubic ramus. This should be more or less a continuous line and should not be interrupted. And we also has the acetabular index, which is an angle formed between the acetabulum and the Hilgenreiner line. I will tell you again that the X-ray should not be used in young patients less than 6 months of age, and even in an older age than that, it's not very accurate and it can be misleading. And it needs lots of experience to diagnose DDH using X-ray. This is an example of an pelvic X-ray showing left-sided DDH. First of all, before looking at the hip joints, we need to check whether the X-ray itself is adequate or not. This one is a good X-ray because both iliac wings are symmetrical, equal in size, and the obturator foramina are also symmetrical. Drawing the lines discussed previously, you can see on the left side that the femoral head is located in the superior and lateral quadrant, which indicates full dislocation of the hip joint. Also, the Shenton line is disrupted, and that also indicates dislocated hip. This is another example of DDH, although I know the X-ray is not very clear, but you can practice on other X-rays to draw the lines and check for DDH. Before we move on to the treatment of DDH, I would like to tell you briefly about the screening for DDH. As I told you before, under 6 months of age, the standard of diagnosis is ultrasound. And after that, X-ray becomes more relevant. So at birth, if the patient has any clinical signs of instability, the ones we discussed earlier, like Ortolani positive or Barlow positive, or leg length discrepancy, i.e. Galeazzi positive, or if the patient has asymmetrical abduction, then the baby needs to be referred to get an ultrasound scan as soon as possible. If the baby has a normal examination, but he or she has a risk factor, for example, breech presentation or positive family history, but the examination is normal, then we refer the patient to have an ultrasound scan at 6 weeks of age. If the patient has no risk factors and a normal physical examination, then it is up to you whether you want to check for DDH or not, but it is not mandatory to get an ultrasound scan. Basically, this is what we call the selective screening, which is screening for cases who has risk factors and or positive physical examination signs. In some other countries, they do universal screening where they perform an ultrasound scan for all newborns. But in Jordan, the standard is, and not only in Jordan, in the most countries in the world, the standard is to do the selective screening. This is a quick outline of the treatment for DDH cases. If the case is detected in a baby less than 6 months of age, which should happen in all cases, then the treatment is easier. We apply an orthosis or a brace. The most commonly used is the Pavlik harness, which is shown in the right upper picture, and this is applied for a few weeks with regular follow-up until the hip is relocated and stable, and until the acetabulum is fully developed. And this is successful in more than 90% of cases if detected early. However, very often we get cases older than 6 months of age, or some cases who do not respond to the Pavlik harness treatment. In this case, the next step is to do what we call closed reduction. This is done under general anesthesia, where the patient is put to sleep and the hip is screened under X-ray, and the dye is injected inside the hip joint. This is what we call an arthrogram, and very often a tenotomy of the adductor tendon is performed, which means dividing the adductor longus tendon, and then we try to push the hip back in place, and if the hip is relocated, we apply a spica cast, which is shown in the bottom right picture. Now, if the patient is older than 1 year of age, or if the baby fails the previous treatment methods, like the closed reduction, then the ideal treatment would be surgical by performing an open reduction. And this is a long incision at the front of the hip to try to open the hip joint and remove all the obstacles on the way, and then put the hip back in place. And sometimes, especially if the child is older, we will need to perform some osteotomies of the pelvis and of the femur if required to allow this reduction. And also, after these operations, the baby will require a spica cast as well. To summarize, treating DDH is best when the child is young. So that's why we need an early diagnosis, and that's why we have screening programs available in all countries around the world, trying to get an early diagnosis and get an easier treatment and trying to avoid surgical intervention. Now, please note that DDH is a silent disease that does not cause any pain to the baby soon after birth. That's why it can be missed easily by the parents and in places where a screening program is not available. The problems with DDH occur later in life. After walking age, the child starts to have an abnormal gait, as discussed before, and the affected patient will always have a limitation in the range of movements. And with getting older in age, they start to have pain in the hip joint, usually after the age of 10 years, and with time they start to have early arthritis in the hip joint. Thank you for listening. As I said, this is a very important topic, and if you have any questions about it, we can discuss it further in the clinical sessions.